everybody, I'm Chris. I was diagnosed with diabetes in 2002. I'm supposed to be the one elegantly segueing questions throughout the panel. Who you haven't met is Mike Evans. Mike, would you like to introduce yourself to the audience?
Yeah, so I'm Mike Evans. I was just thinking about this panel, and the data is about 1% of healthcare is provided in an academic hospital, which I kind of connected to. About a third of care is given in sort of primary care, so family doctor, nurse practitioner, pharmacist, physio. And the rest happens at home. And when we think about healthcare, we probably think more about the first one or two and maybe less about the third. So just to introduce myself just for a minute. So my kind of work kind of spans all those. So I'm a family doctor. I'm an endowed chair at the University of Toronto in family medicine and public health. And I see patients at a hospital called St. Mike's, which is an inner city hospital. And then just to kind of storify it, I was sort of a typical academic physician, and then I kind of did a career jump, and I started a medical school for the public at the University of Toronto. And that was fun, and it kind of led to us developing a media lab. So I run a kind of big media lab with filmmakers and designers and illustrators, patients. It's all sort of social entrepreneur run, and we do everything from infographics to peer-to-peer. So we did a documentary film with 50 Canadians about their experiences with cancer, psychosocially. To we run a big med school on YouTube. So if you look at Doc Mike Evans on YouTube, we've had about 10 million views of our medical school on YouTube, which is totally free to the public. And we're launching something called the Better Life Experiment, and so on and so forth. And our whiteboards are basically a filmmaker and an illustrator getting together, and I sort of tell a story around a clinical condition. And we've done everything from low back pain to we're just releasing one actually this morning on early childhood brain, which was resonant with the talk this morning. One coming up on low risk drinking, which I could have used last night, and. So I'm sort of sitting in all those spaces, but I would say I haven't quite connected them, and so I'm curious to see how it rolls out today.
So as I was taking notes during everybody's speeches, well done, by the way, I wrote the word relationship down 3 different times, and it seems like a no-brainer for me because I'm the patient and I should have a connection with whoever I'm seeing as far as medical advice or prescriptions or whatever the case is. But why do you think it's been difficult to kind of re-educate providers as far as, hey, the relationship is, if not the most important thing, it needs to be like the top 2 kind of aspects of providing care for somebody? Vivian, you want to start with something like that?
I think that's a really great question. I think all of us, when we go into medicine, are going into medicine in order to care for patients, and then our attention is distracted by everything from insurance company negotiations to AMRs to, the business of healthcare. And for us, the exceptional patient experience and the idea of having patient satisfaction or patient responses fed right back to the provider, you think that would naturally happen just in the course of a visit, but in a visit in 15 minutes or 10 minutes, it was really helpful, I think, for our providers to get redirected back to realizing again that the patients are why they're there. And once they had that initial kind of nudge, then it kind of came naturally again, right? I mean, that's why we're all here. And it was, I think one of the things that was implicit in all those graphs where you could see improvement was it was very rewarding for the providers, right? There's nothing like positive feedback to reinforce that behavior, right? So when you start reading good comments about yourself online that your mother and your neighbors can read, wow, it feels really great again. And so they kind of get you back into that positive groove.
So, Anne, what about you? I mean, you, in your presentation, you just mentioned that you're elevating the patient within the team and you're focusing on that relationship building aspect. I mean, what was the most difficult part of trying to get everybody on board with that process?
Well, we hired people for empathy, really, and that we were able to assemble a team de novo, and with that concept in mind. I think that in many primary care settings, as you pointed out, that there's not the time, and you have to do all this extraneous things that aren't really what doctors are licensed to do, and by being in a team situation, you can really spread that around.
But they might not be licensed to not care, but to be involved in that specific part of the relationship, but they are human first.
Yes.
I feel like the relationship I understand that there's the practice and there's the medicine and there's all those important things, but I mean, shouldn't the human factor really be an important key of all that?
Well, we hired our medical assistants from within Stanford, and we actually asked clinic managers because they're basically their job is to room the patient and do vital signs and then get out of there. And we asked them, who are the people who are getting in trouble for really getting to engage with patients? Because they're the ones that we want. And and their job description prohibited them from that, and the physicians didn't have time. And in some instances, that people are really able to make bonds with their team. I'm not saying it never happens, but that the structure of the system is not really set up with that as the goal.
So this might seem like a no-brainer to people in this audience, hopefully, but Erin, what does it mean to you whenever you are able to build and kind of foster that relationship with your providers, especially in the case of your son?
It's critical. It's really critical. And I think something that several people have touched on here now is that doctors are trained to do stuff for patients and not with patients. And so if we're working together, we can get a lot farther because we don't appreciate how much patients are already doing and are capable of doing on their own and at home. And what we bring to the equation, if we can do that with you, we can get a lot farther.
So, Mike, whenever we were chatting before this panel, you were talking about the fact that you need to have that relationship first before you can really start to provide the actual specific care that's needed. Can you elaborate a little bit on that?
Yeah, I mean, in the clinic, we're doing a trial on email clinics, and a relationship is sort of the most interesting part of it. So is my relationship better with the patient if I see them 5 times a year, or if I see them 2 or 3 times a year but have 7 emails with them? And my answer is the latter. But I feel like, we're putting all this emphasis on quality improvement and electronic health records and all this kind of stuff. And I feel like it only works if the relationship becomes better. So in Vivian's example, it seemed like the relationship actually got better. And how that plays out clinically is I find myself sort of staring at the computer doing all the things I'm supposed to do, and I forget that I need to look at the patient. So I think that's point number one. I would say in our media lab, I spend a lot of my life telling patients data, and stories trump data, and relationships trump stories. So we build infectious media that people want to give to one another. So you're much more likely to open our thing on low back pain or acne if you get it from a friend that you adore or trust. And so I think on both sides of my life, at least in the clinic and in the media lab, it's understanding relationships is critical to the pathway.
So we've got a couple of questions from Twitter. This first one, I'll let anybody chime in if they want. This is from Sherry Reynolds. Most care happens at home or in community. How can we support home or community care? Anybody?
Well, I just have time for a quick story. When I first went into family practice, I took over a practice in Humboldt County. I took over a practice from a woman who had really burned up. I mean, she was everything to her patients. And one of the patients came in and had a chart this thick. It was back in the paper chart days. And the doctor had only been gone from the community 2 months, and she said, "What was that doctor's name?" So I really realized, that really brought home that you're just a small part of people's lives. So I think that the emphasis on, we try to get as many people as possible to do the chronic disease self-management course, developed by Kate Lard here at Stanford. We try to give them the tools to take care of themselves. We connect them with community groups, and patients like me, and really, because that's where you get most of the information. How do you live from day to day with things? So I think that really expands the capacity of the clinical team to think of how do you get the rest of the team going in the community.
I think the other part is just, I don't quite understand why diabetes care isn't happening at the YMCA. I mean, they see me 3 times a year, and they're going to the YMCA, every week, and there's a big social network there. And so I think we need to kind of, to answer Sherry's question, we need to kind of move care out into that, just into that community. And then I think there's so many ways we define community that, and a lot of people define it by their disease or their neighborhood or whatever. And so I think we just have to kind of get into those communities of practice. And, you know, a lot of our work has been filming, instead of filming experts, we move the patient to the expert and we film patients talking about, you know, how to tell your kids you have cancer. And there's no perfect way to do that. And so we film people talking about their mistakes and what they did. And we will have a grand fromage at the bottom, you know, sort of saying what it is, but we actually interview people, and it's unscripted. And I think there's a power to that and allowing people to kind of choose who they're going to get advice from.
I think too that there's a wall between us, between patients and providers, and taking down that wall will go a long way in opening up the conversation. And I think a lot of the time, I know even during my talk, I talk about how I'm more than just a patient. And I think that patients expect doctors to care about them 24 hours a day, 7 days a week, 365 days a year. But we have to realize that we're just a blip on their radar too. And so as invisible as we want our diseases to be to us in our lives, they're trying to help us, but they have a life too. And so working together, I think, you know, combining those small pieces of each of our lives gets us farther, faster.
Yeah.
We try at Stanford Coordinated Care, I mean, you know, because we're capitated and we don't rely on generating RVUs and bills for services, we deliver a lot of care between visits and not by in the clinic. We have our care coordinators average one touch per patient per week, you know, of back and forth conversation. And so emails, our doctors take 24/7 calls for our patients. Because that's it, and it's easy to take a call from somebody you know at night, and oftentimes that heads off emergency room. They just need more information or reassurance and say, I'll see you tomorrow in the clinic. So I think accessibility is really important, particularly in a case like apparent or cystic fibrosis. That's what you absolutely need when you have a crisis. You need it right away.
You know, I will just say as an administrator, we take care, you know, our system has a hospital and we have clinics, primary care, but we are not responsible for home health, right? So it's not an area of expertise. I think it's a really, really great question because I'd say, first of all, we have to create financial incentives for healthcare delivery systems or providers to care about what happens at home. And then we need more research to understand just how we can impact with the greatest effectiveness the home component of healthcare. I'd say because we've never cared about it, we've never thought about it very carefully, we don't really know. There's a researcher that I really adore named Benga Ogedegbe out of New York City, and his research studies have been in African Americans looking at management of hypertension, just common chronic diseases, and really getting out through the church communities. I'm just responding to your YMCA, through the church communities and then through barbershops. And I think we need more research to really understand where do we impact our communities the most effectively, and then we need to create financial structures to incentivize that.
All right, Vivian, this is a question directly for you. Have you changed your medical school curriculum to teach engagement?
That's a really great question. So we are absolutely trying to transform our medical school and residency and fellowship training, because it's all that continuum, that decade that they tend to spend with us when they're training, to really try to focus on preparing our healthcare professionals of the future. And as I say, we've just welcomed the whole new crop right in July. And as I said to them all in each of the town halls we've had, I said, you know, I want to train you to be the kind of providers that I want to hire in a few years. And part of that is the patient engagement, and part of that is being really tuned into the quality, the cost, the entire spectrum of the value that we're trying to deliver. And as somebody who went through medical school, never once seeing a patient satisfaction score, having no idea of the cost of anything I ever ordered, and really not knowing about outcomes once the person left my service, I think this is a huge, huge leap that we all have to take, but I think it's really important for the future.
All right, quickly from Mike, this is a question from a Canadian, although I think it should have just said Canadian A. How have you been able to email patients? Don't privacy laws prohibit that?
How have you been email?
Email.
Yeah, so I do it totally illegally and on the side and against our hospitals. Sorry, Vivian.
It's a good thing we're streaming this out to the world.
Yeah. Hopefully nobody's watching in Canada. Yeah, so it's interesting. Three of us sort of did on the side. So one guy who's just starting practice and he's getting overwhelmed. Another person who mostly does HIV primary care and family medicine and wants to kind of broadcast to her community. And then me, who's less in clinic and needs to kind of patch through when I'm not there and I'm in California. So we don't get paid for it. And we just sort of are experimenting with it. And, that's not going to work for clinicians in general. And but at the same time, I think that's a big part of quality improvement. It's not just plan, do, study, act. It's an attitude. It's about micro experiments. And our motto in our lab is "We Suck Less Incorporated." So we put out something that sucks a little less. But trying to figure out, am I going to give this a 72-hour, I'll respond to you, but most of the time we respond quickly, or am I going to have a clinic from 12 to 5 where I take all your emails? All these things, we sort of experiment with all these things, and it's so much fun. And we actually started it because I had an 87-year-old patient whose husband has Alzheimer's say, "Mike, I can't make it in, so can I just email you?" And you can't say no, right? So you kind of go with the flow. So it's not illegal. We can do it, but it's and we have a kind of lockdown platform that we sign off on. But it's been a bit of a journey.
All right, so we've got, according to the clock, about 8 minutes left. The one thing I didn't hear about talking about the new team expanding quality of care and just kind of re-educating, rebuilding everything is the internet. The internet is a part of my healthcare team. How do we safely and properly allow doctors and specialists or whatever to integrate the internet into their patients' care? Because my former endocrinologist would never have told me, hey, go check out Twitter, go check out diabetes blogs. It's been a life-saving thing for me. Obviously, it's not for everybody. You have to go at your own pace whenever you're ready to engage with that kind of thing. But how do we safely incorporate the internet into the new healthcare team?
Well, at Stanford, I believe we have. We use Epic, electronic health record, and I understand that half the patients in the country are in a system that uses Epic. But one of the features is a secure messaging, so patients can send in messages, and the security's set up. I think the problem is that my son-in-law is a family practitioner and works in another health system. He does that at the end of the day after seeing their patients every 20 minutes, so that there isn't. It becomes another burden or another jelly bean in the provider's cup, and rather than a joyful way to communicate with people. So
maybe I should have been a little. I'm sorry, but maybe I should be a little more specific. How do we safely incorporate the social internet? I'm talking about Twitter. I'm talking about Facebook. I'm talking about blogs. I'm talking about my peers with diabetes that are sitting in the front row right here. How do you as a provider safely inform me that's like, hey, there's a community out there. Go find them if you need support, if you want to talk with other people about it. Whenever my 15 minutes is all we have. But the Twitter is on 24/7. That's out there if you're ready for it. I mean, how do we safely educate our patients about that?
Well, actually, I forgot to mention that one member of our clinical team is a Stanford health librarian who comes to our. We have patient case review every week, and they have a great service of. We know that there are websites for people with different conditions, but they'll actually sit down with somebody and find the one that resonates with them. So if you have a particular kind of cancer, you want to, male your age to, communicate with, they can help find it.
I like that.
So it's a luxurious thing we can do.
Yeah, Vivian, what about you? I mean, we were just talking about education. I mean, it's your med students are now coming in. I would hope that you're probably looking at their Twitter and Facebook profiles to see if they're going to be, upstanding individuals representing your institution. But I mean, how do we translate that into, hey, by the way, your patients might enjoy Twitter as well for that kind of social support?
Yeah, so I think that Anne's idea is right on. We also have a very active librarian service that's really focused a lot on patient education. As part of that education, it's trying to direct them towards other sources outside. I guess my feeling about it is I think social media is incredibly valuable, and I think that it should be encouraged. Your kind of a blog is just really, really important. At the same time, I think it's also important to have some points of connection, and maybe this is just because I'm from traditional healthcare, but to have some points of connection between these social media hubs and health systems. And I'm for example, I'm prompted by what you just said to me off stage, which was when I started this blog, people were writing about suicide, thinking about suicide. And as a provider, that raised some huge flags for me. So I would want to make sure that within social media, whatever is able to come out there, that there is some link to, for example, as we were saying behind stage, some ability, if somebody's talking about something that you're really worried about, that there's some way to connect them to a provider who can look after them. Because I'm worried that just out there in that, ether, there might be people who are revealing really important things, and it's not getting connected back to people who can really help them.
Yeah, there's a happy medium between go on the internet, have fun, and
Right.
I'm the licensed professional. My advice should also matter to what we have to do as well. Mike, you gave me your business card, YouTube, Twitter, Facebook, Google+. All these things are on here, so you're well-versed in social media. How do you manage that when it comes to recommending different options for your patients?
Yeah, so, I think, I'm a fan of Dr. Google. I think it kind of kicks ass, and I think it's great, but it's obviously, it's a double-edged sword, and pre-diagnosis, maybe not so good, because if you have a lump that's turned into a cancer, you might set up a web page, but the other 100 people that have had lumps that have gone away don't. So there's a kind of selection bias there, and there's selection bias about people trying to make money off of whatever you're doing. So, but overall, post-diagnosis, unbelievable. I think, if you look at the cancer literature, I'm just thinking of the patient in front of me. Some of my patients are what the cancer literature calls blockers. So my dad would be that. If you diagnosed him with cancer, he would want to talk to one or two of his friends and would totally trust his clinicians and his doctor and his nurse and whoever, and that's it. That's fine. My stepmother would go and she would do some social. She would call the 1-800 number. She would get involved, and that's great too. And now we're having more the people who are what I call the sharers. So they go through their experience and want to share and want to talk about what they're doing. So we just, one of my son's girlfriends, it sounds like he has a whole bunch of them. His friend's a girl just got sadly diagnosed with Hodgkin's. So we're filming her explaining Hodgkin's to she's a kind of slightly unusual 15-year-old girl with Hodgkin's. So we're filming her explaining it to other people, and there's a power to how she would explain it. And then, for clinicians, if the question I always get, if my patient wants to follow me on Facebook, do I let them? And that's an easy answer for me, no, because on your own personal Facebook channel, you're putting on all your, here's my trip
Cat.
with, I don't know, I don't want my
pictures,
patients there.
basically, yeah.
But I tell them, set up a Facebook fan page that's set up around your interest, whether it's, gastroenterology or orthopedic surgery or whatever. And you can just post all the great stuff there, and you drive your patients to that. It's purely clinical, and it's easy to do. So, and then the future is obviously, if you have high blood pressure, I'm going to prescribe you an app because I'm only seeing you 3 times a year for your high blood pressure, 4 times a year. The app's following you every year, and it's going to data visualize that back to you. And Siri's going to say in a Jewish mother's voice or a Scottish mother's voice, you're not moving enough, and you didn't take your medications. And it's going to tell you when you're actually gaining, you might be able to go off your medication. And I'm going to drop in one of my whiteboards. And other people want to be social around that and compare the results. And other people, so it's all these, you'll see all these nudges come out. And it'll crash initially because we won't be able to kind of contextualize it for people, but you'll see in the future that if we can build all these nudges that are much more personalized, and it'll come back to what we're talking about, relationships and so on and so forth. It'll just take a while to get there, but that will be the future, how we'll be there with our patients in a more powerful way.
I think you and Dr. Mike Savillo should have a really interesting conversation. He's in the audience somewhere. I think he's wearing a yellow tie, according to Facebook. You should find him after the fact.
Can
Erin,
I add on to that
I was
really
going to say, good,
quickly?
because you mentioned that your team includes other caregivers and peers. The internet has helped you
does.
find all of those
Yeah,
people.
and I think, I think there's a really underappreciated value of the empowering nature of those social connections, especially when my doctor recommends them. So if my doctor is saying to me, go to this community and talk to your peers, I know they trust it, which makes me trust it a little bit more. And then they invite me to bring that conversation back to the table. So they might say, no matter what it is, and they might say, I don't know the answer, but let's figure it out together. Let's go online, let's use both of our resources, let's work together to solve this problem.
And that's different from the the push in medical school is to know every answer, answer to every question, so that's good that you have providers like that.
Yeah, so we're about to leave. I just want to leave it with a quick anecdote, especially coming off of your presentation. And I moved to San Francisco at the beginning of the year. I had my endocrinologist appointment for the first time in San Francisco last week. And instead of 15 minutes, I had an hour. I met with a certified diabetes educator. My endocrinologist was in the room at the same time. One of them was on the computer scribing while the other person was looking me in the eye, and we were having a normal conversation. And I left with the biggest smile on my face. And it's something that I've never experienced before. I mean, I was diagnosed in 2002. I've had the same endo for the most part. And like I said, he would never recommend the internet. And I walk into this place, and it's like, hey, do you want to sign up for our online health portal? You can send us an email. These are mind-blowing things to me. And whenever it happens to me, when anybody new for the first time, it's empowering, it's encouraging, makes me want to take better care of myself. And it's a really beautiful thing.
That's great. I think we need to risk stratify patients and provide minute care to people who really don't need, the 50% of people don't need much, but really then devote the resources to people who have ongoing health conditions to make them thrive.
Yeah, all right, so that's a perspective on the new team. Obviously, the team is always growing. Thanks for paying attention and your questions, and let's go get a Diet Coke. Thank you.